This is Urban Health Today, and I'm speaking with Dr. Damien Croft, U.S. Regional Director of Medical Affairs for Maternal Health at Organon. He's here to talk about Organon's efforts to address medical bias for improved women's health outcomes. Thanks for speaking with me today, Dr. Croft.
Thanks for having me.
It's great to have you here. So let's begin. Please tell us about your background and your work with Organon.
Yeah. So it's interesting. Before I even came into pharma or the industry, I worked for 15 to 20 years as a clinician. I was an OBGYN and I practiced high risk pregnancy, mostly in the Philadelphia region. And then, different things happen in your career. And I end up at, starting an industry in pharma. And our company, Organon, is kind of a child of Merck. So we were kind of like spun off from there. And initially, it wasn't really clear what that spinoff was going to be. And then as it developed, it was like, wow, this is going to focus on women's health and developing products in women's health. And that focus to me was obviously appealing, given my background. And so I moved over to Organon, and it's been exciting because it's the first time I've had in the industry setting to work on products specific to women's health, developing new medicines, things like that. So it's really been exciting from that standpoint.
Can you share some of the top disparities that women, especially those from minority backgrounds, face in their journey from pregnancy to childbirth?
Yeah, so I think we kind of unfortunately all know about the disparity in maternal mortality rates. It's 2 to 3 times for both Black women and also, AAPI women compared to white women in this country. But there's some detail in that as well. So I think, there's other things like preterm birth rates obviously are much higher in Black women. And then the postpartum period, which I think is underappreciated in terms of I don't want to say danger, but in terms of the risk and in terms of the disparities there. And for Black women specifically, there are different risks or differential risks, I would say, compared to other groups. So like in particular with cardiovascular issues, heart attack, cardiomyopathy, those are things that are affecting Black women disproportionately. And then, one other thing I'll add is mental health. I think obviously we can't think about maternal care and healthcare in general without thinking about mental health. And we know that mental health is something that's affecting us generally as a population. And within pregnancy and postpartum care, Black women have high rates of mental health issues that are either diagnosed and undertreated as well.
So as a physician, have you ever personally witnessed medical bias affecting a patient's care? And how did this experience shape your approach to practice in medicine?
Yeah, it's interesting. So I was lucky to practice in a situation where I actually had a lot of Black physicians around me, which was great. So people that I trained with and trained me, looked like me and looked like some of a lot of the patients we took care of. But still, there's other obviously majority groups. And still the other thing is that it was less specific to race, but it was that intersection between kind of race and class, right? So we had a lot of either women who were poor, and also like we had a large immigrant population where I practiced. So I did a lot of my practice in Philadelphia, and we had a large immigrant population. And, obviously like those women were already had anxiety because they were in a new place. They were, dealing with a completely new health system. And, I think a lot of times providers don't feel comfortable as well. And that discomfort is sometimes expressed as bias and as like negative treatment towards certain populations. The one time I would say I had an actual really kind of overt, explicit bias that I saw, it wasn't related to race. It was actually related to weight and obesity. This was I remember it very clearly, it was during a surgical case, an older white male physician who basically just kept making really kind of rude comments about this patient's weight, and the patient's under anesthesia. And it was really kind of a jarring and disturbing situation for me. Wow. So, that taught me to really not even just unconsciously, but consciously think about what my partners are doing, right? At that point, I was in the position of not having power, right? So I didn't feel like I could kind of question what he was doing. But I think physicians and other people, healthcare providers need to kind of look at their partners and be like, hey, the way you're thinking, what you're thinking about, how you're presenting to your patients, is that appropriate? I mean, I wish I had had the courage to maybe do that at that moment, but I think that that's one thing that we can all do as providers to help make the system better.
Was that an anesthesiologist that you had that experience with?
No, it was actually the GYN surgeon.
Wow.
Yeah, yeah. It was, like I said, it was disturbing, but I'm a resident, right? So I don't have the power.
Right.
There's
You're
also this
new.
huge power discrepancy, right? Between your attending who's up here and me, the lowly resident.
Right.
So who am I to question him? You know?
Well, can I tell you of my childbirth experience? So I had my daughter, it was uncomplicated.
Good.
I was gonna go for no drugs, but then
Hmm.
the pain was so much that my midwife was like, look, you're not gonna enjoy the birth if you don't take the anesthesia.
Hmm.
So brought
Hmm.
the anesthesiologist in. Everything was fine up to that point. And the anesthesiologist was so rude. I just couldn't get over. I refused to let him ruin this experience for me, but he was just so rude and so inappropriate. And you've got somebody, working on you, and he's sticking this needle in my back and everything.
Right.
And, I wanted to turn around and say, like, do you talk to all your patients like this? But he's putting something into my spine. So I didn't really want
Right.
to move her. But my goodness, like that alone would have ruined the experience for me.
You know what?
Mhm.
To that point, though, I will say, and look, I've worked with some amazing anesthesia colleagues, so I don't want this to come off as like a disparagement of anesthesiologists, because I work with some
No, of
amazing
course not.
obstetrical anesthesiologists. I will say, though, you just triggered me to think. My wife did tell me, because I wasn't in the room when they were positioning her, so she had a C-section. Our labor was arrested, and
Right.
she had a C-section, so they moved her into the room first. And she said the anesthesiologist also commented on her weight, and she was really upset. Yeah,
No.
yeah. Now I wasn't in the room, and I tried not to talk about being a physician, because that's sometimes that can go both ways.
Right.
Um, so yeah, it's interesting that you say that. So there are. I will distinguish, and I don't know if this is the situation where you were, but there are dedicated obstetric anesthesiologists, and then there are anesthesiologists that kind of like cover the labor and delivery unit. And I wonder if there's a difference between those two
I
groups.
think
I
he
don't
was
know.
covering because he wasn't planned. He was called in last
See,
minute.
yeah.
He
So
wasn't part of
sometimes
the original plan.
right. So sometimes it's probably just that, like they're not used to working in that population and in that setting. And labor and delivery is such a kind of like different setting than anywhere else in the hospital, right? Like it's obviously different than a regular OR. You have patients and patients' families involved. And, I think for some anesthesiologists who aren't used to that, it's very disorienting for them.
So healthcare provider mistreatment can have a profound impact, obviously, on childbirth. What are some policies or practices that healthcare providers can adopt to prevent this?
Yeah, I think there's a couple of things. One is I think that I will say this is I think there's a generational difference too. I think that, and I'm older, right? So I think that my generation of providers are going to have a different perspective than the younger generation. I think they're way more tuned. I think they're way more like kind of understanding of like that these biases exist, and we all have them, right? Like everybody has
Of
some of these
course.
biases, like understanding your biases and really trying to work on those. So I think obviously there's different groups that are working on kind of like doing bias training. I know for something we're doing internally as part of our birth equity work is we're going to kind of help to fund some medical bias training, right? So that's really important to do. That's number one. And I think that just by people acknowledging their bias, that's hopefully going to make a difference. But I think the other thing is, and we just talked about this, is trust. And I think you can't, and this is very squishy and it's not even very scientific. So I feel as a doctor is kind of like maybe out of my swim lane, but it's really like you have to be, as a patient and your provider have to be in a situation where there's mutual trust,
Right.
right? And it's funny, I talked to a couple of friends of mine recently. I just went out to dinner with a colleague. He trained me, not the same doctor I talked about before. He trained me, and I kind of just asked him like, what's going on out there? Because he's still practicing actively. And he said, the one good thing is that more women are coming with birth, like assistants, like doulas and things like that, right? The one problem is that now it's almost becoming like confrontational. I think that's not the way it's supposed to be, right? It's really supposed to be that that person is an assistant and kind of another set of eyes and ears. But you really have to be in a situation where you trust the person you're with. So like your provider, the setting you're in, all of those things. So like maybe you want a home birth, and maybe you should do that. That's where you feel more comfortable. Or you want a hospital-based birth. Maybe that's where you feel more comfortable. And obviously the person who's you're seeing, that's your primary provider. Like you said, you wanted somebody that looked like you. That makes people feel comfortable. Then do that. Then really go and find that right provider, because if you don't, then it's going to kind of breed this mistrust, and it's going to increase the kind of like implicit biases that are probably there, because I think both sides of the equation kind of can feel that lack of trust.
That's not always possible. But what do you mean by confrontational? Can you explain that?
I think that it's really getting difficult so the doctors and the midwives are there to kind of like do what they think might be the best thing from a medical or labor and delivery standpoint.
Okay.
And I think that now we have, another group of people that are coming in. And I think it's important that we have that, but we want those groups to work together. The doctor, midwife, doula, other birth attendants should all be working together toward the same goal. There should be shared decision making in terms of how you're planning your pregnancy and how you're planning your labor and delivery experience. But it shouldn't be that they're working kind of at cross purposes, because I think that actually ends up being a dangerous situation in some ways.
Historically, medical doctors have not been very welcoming to not doulas, because doulas, that's sort of starting to come back, but to
Mm-hmm.
midwives. And I'm wondering if
Mm.
that relationship is improving. Have you seen that in your experience?
So I probably have an atypical experience. So where I trained, we had a really large group of midwives.
Mhm.
And so I don't know any like obstetrical care without having worked with midwives. And it's great because they definitely bring a different perspective, right? Like
Right.
physicians are like, look, we're trained to treat pathology, right? And they were always like, don't pathologize normal. So they were there, they kind of helped in my education, because if there was pathology, right, somebody had preterm labor or preeclampsia, I'm on it. But if they had a relatively normal birthing experience that was kind of ongoing, they're like, you don't need to intervene. Like, don't keep your hands off. That's probably the best thing. Stay away from the patient, you know? And so it was, it was a good balance for me. It was a good place to train. And it was a good kind of like concept for me to keep in mind. So I may not be able to answer that question the same way other people would, because I just trained with midwives for like my whole career.
Well, that's good and encouraging to know.
And
And
I think that's becoming a little bit more common.
mhm.
It's not everywhere, but I think it might be becoming a little bit more common to have more midwives involved in care.
Organon has been proactive in tackling disparities, particularly through enhancing contraceptive choices. Can you
Mm.
elaborate on how increasing contraceptive access can influence women's long-term health outcomes?
Sure. I mean, I think it's one of the most important things because, we know that. So I'm going to talk about short interval pregnancy, for example, which is defined variably less than 12 months, less than 18 months between, time of your delivery and the next conception. The short interval pregnancies actually increase the risk of lots of things: maternal mortality in general, preterm birth, other kind of adverse pregnancy outcomes. So having access to contraception and appropriate contraception, right? And different women are going to want different things, can
Right.
actually help improve those long-term outcomes by spacing deliveries and pregnancies appropriately to provide that time for women to heal and get healthy, and to not have some of these adverse pregnancy outcomes that are related to having that short pregnancy interval. So I think that's number one. And I think the second thing is, and maybe we'll talk about this a little bit later, is there's an economic component of that as well. We know that women who are able to kind of control their contraception and control their pregnancy timing are less likely to be in poverty. And that's a really another important component of that, which is, giving women the power to control their reproduction and not have unplanned pregnancies, which can kind of change your kind of socioeconomic status.
Can you discuss any successful collaborations that have effectively addressed maternal health inequities?
Yeah. So I think, we're early in this, and when I say we, I'm talking about everybody: government, industry, nonprofits, community-based organizations. I'd have to admit, like, if I had to point to one place, it's probably California. There's some work they're doing out there, CMQCC, and they actually, that's one of the few states in the country that's seen maternal mortality rates actually decrease, over time. And I think what they've done is include community groups, been very intentional about trying to have like patient care care bundles in terms of like things like postpartum hemorrhage and other, hypertension and things like that. And that focus has really made a difference. But for the rest of the country, I think we're still in the beginning phase of this. We're just now, it's like we're finally in this moment where everybody's recognizing what a problem this is and coming up with the different interventions. So hopefully we'll be able to replicate what they've done in different areas of the United States.
Can I ask you why the recognition? I mean, this has clearly been going on for a long time. Why is
Mm-hmm.
it now being recognized as a problem?
Yeah, so it's really interesting. So there's two parts of that. So there's like kind of the clinical and academic information, and then there's the kind of lay press. On the clinical and academic side, you know, there were actually articles as recently as I think like 2014, I was reading something where they're like, well, maybe this is a statistical anomaly because there was a change in some of the reporting for maternal mortality where they like added a checkbox to death certificates. And they were like, well, we think this is really just a statistical anomaly. And maybe there's not really a change, right?
Okay.
And I think it wasn't until probably like the most recent, there was a CDC report looking at what they call maternal mortality review committee data. And
Okay.
that's where, you have groups that are looking at not just kind of like large epidemiologic data, but like actually looking at individual patients and their outcomes and kind of their whole pathway and what happened and what can we attribute the death to. And they can say that, looking at these individual cases, 80% of this was not only like pregnancy related, but it was something we probably could have prevented. And so I think that it took a while for the data to solidify on the kind of like clinical academic side. And then the lay press started to finally pick it up over time. And then you had lots of articles about that. But it just took time, and an unreasonable amount of time, but it took time for it to get from the clinical side for people to really understand the data and what's going on from an epidemiologic perspective. And then that translate into kind of the lay press side. And then when you finally have all these other stories, like Serena Williams' story came out, right? Like about her experience in birth. You had some other, the track stars that have recently come out, like Tori Bowie and Alex and Felix, talking about their experiences. Like now you have like, which is actually perfect, these anecdotal things that kind of like supplement and provide a human face to this like data, and putting those two things together. Finally, I think people, they get it, but it's just taken a lot of time.
As you know, education and
Yeah.
economic independence are key to empowering women. What specific programs does Organon support or plan to initiate that target independence and empowerment?
Yeah, so I think her promise initiative is one of the things, and things that all the work we do in contraception that we kind of touched on earlier is important because, again, I said this earlier, it really is an economic and a financial aspect to controlling contraception and controlling and planning pregnancy. And women who don't have access to that for whatever reason, this is in the US and globally, they just do less well. They're not able to kind of plan their family. They're not able to plan their entire life. They're not able to, if they want to defer, childbearing so they can work on their career, or if they want to have a family earlier. So, I think that it's really important that we provide contraception, and especially given the situation that's going on in the United States now, right, with Supreme Court decisions, what have you, it's going to be even more important because we're not going to have other options available, at least depending on the region of the country you're in.
So circling back to what we were just talking about, the racial disparity
Mm-hmm.
and the bias. I'm curious if Organon has done, and if you don't know the answer to this, that's fine, but I just
Mm-hmm.
wanted to ask, is there any work being done to increase the number of doctors of color, female doctors? Is there any of that work going on, even if it's not Organon, do you know?
No, we have some very specific work, and my boss, basically Charlotte Owens, she's actually been doing some initiative with HBCU specifically to support, that's where a lot of our Black physicians come from. Actually, ironically, the friend I was just talking about, who was my mentor, he's going to Howard's graduation this weekend, and or in Howard's, he's having their like 30-year reunion. So, and that's where a lot of those physicians are going to come from. So, the support we're doing in that space, I think it's very important in terms of like having just more, you know, Black and minority physicians in general to treat the population to kind of hopefully ameliorate some of these biases that we see in care.
And you think that education should be like in the medical school curriculum, right?
I would think it starts in the medical school curriculum. Exactly. It starts from medical school and goes on from there. It's just like, you know, when I was in medical school, we didn't talk about social determinants of health at all, right? It wasn't a thing. It was like, you do your clinical care, whatever pathology you see, you treat that. Now we know, like, well, before you even get to all that pathology, just like in maternal mortality issues, unrelated issues, there's all these social aspects, transportation, your job, your education, where you live, that
Childcare.
impact, that we didn't talk about that back then. You know, I had to do a public health degree to kind of get that get that knowledge that was outside of my medical training. And I did it after I was done. I was already attending, I was already practicing, because I'm like, there's something that's missing from my medical education. And what is it? And it really is this like larger view of the world that surrounds your patient. Like, you can treat each individual patient and you treat their pathology, but how do you prevent the pathology, right? Like, how do you understand that world that that patient is living in? And that really is what my public health degree taught me, that I didn't learn in medical school. I always said it was like, just like you said, the kind of extra part of medical school that I didn't get when I was there, that I had to come back and get later. And that gets back to one other thing that I didn't mention earlier about like what is Organon doing that's different. And the other part of that is research, right? Like, if you don't study certain diseases and certain therapies in a broad population, you're not going to know what to do, or you're not going to know if it works in those populations, right? And so for years, like, most clinical studies were mostly men. And then, you know, and obviously that didn't necessarily encompass the entire population. And also, I think, you know, the thing is that then it was mostly among white people. And one thing is that Organon, I think, in a lot of their clinical development programs, is been very intentional about making sure, like, is you have a diverse group of patients involved in that care. And so that's why, despite the, you know, kind of historic concerns that Black people have about clinical research, it's critically important that we're actually involved, because that's the only way then that people know how to treat down the road when these therapies come out. Do they work in this population? Well, it's never been studied in that population. Well, how will we know? So it's really important that, you know, minority groups are involved in the clinical development, so that later on when these treatments come out, we know that they'll work, or they'll work just as well, or that they don't, and then we need to do something else.
Right. Well, this leads into our next question. Do you know of any recent advancements or tools developed to assist healthcare professionals in recognizing and combating healthcare biases?
I don't know any specific tools. I know that we're doing a lot of work, like Organon's doing a lot of work with CBOs. And I think that that's where the community-based organizations kind of come in, you know, and I've said this internally, like, hey, we at the inside the pharmaceutical company are probably not going to be the best ones to say, like, this is what we should be doing on the ground to prevent implicit bias. But the people who are on the ground, the community-based organizations, the lived experience experts in those organizations, are the ones that we should support, that then can tell us, like, hey, this is where the money needs to go for this specific program. So like I mentioned earlier, or some of the birth equity work we're doing, I'm actually being told, like, hey, this is the program that's, you know, going to be probably the best one to train providers to look for implicit and explicit bias and kind of like do that work. And I'm like, you know what? I'm going to take you're the expert. I'm going to take your knowledge and expertise, and I'll say, hey, let's, you know, put some funding behind that. So I think it's us kind of like acknowledging like what we know and what we don't know, and kind of like giving that expertise and listening more than talking, so that we know where to put those funds and where to work on those initiatives.
You know, this implicit bias thing, this implicit
Mm-hmm.
bias,
Mm-hmm.
I find the whole thing so curious because um, I just, I'm not entirely convinced that you can erase years of how a person thinks
No.
uh, with a training. I mean, training like that would have to be years and years. It would have to start really early for it to make a huge impact. Or are you seeing something different? Because I feel like the answer is that medicine needs to embrace the idea of more diverse providers, not just
Uh,
nurses, not just PAs,
right.
but physicians. You know, we need
Yeah.
more physicians, of Latin heritage. We need more physicians of Black heritage. We need more of these because also patients trust doctors who look like them. I just don't
100%.
know that implicit bias goes far enough, or have you seen something different?
No, I don't disagree with you. I think that implicit bias just puts the seed in like, hey, let me think about this. Like you said, you're not going to change somebody's mindset or how they operate with one day of training. So I think, is there some benefit? I think there's some marginal benefit. And I think it's good to like have people think about it. But I think you're right. I think overall, the biggest thing is, like you said, having more providers that look like the population so that people feel like they can have a provider that looks like them, that they feel comfortable with, that they feel like that's not even an issue. Now we can just deal with my health. So but I don't think one is exclusive to the other. So I don't think we shouldn't do the bias training. But I do think that probably the more important issue is like training a workforce that is representative and that looks like the population so that we can have those providers out there. But that's been an issue in this country for, years. And the reality is that the needle hasn't really moved on that.
Right, right.
Yeah. Yeah. And that's an issue that's way bigger than one company, right? Like just Organon is not going to fix that. There's like a lot of government policy that goes into that, obviously the kind of academic training environment that goes into that. I forgot her name now, but she wrote a book about kind of like her training experience. But, the academic training experience, and I went through it, can be, you want to talk bias, there's a lot of bias there. So even if you get in, it's kind of like navigating through that world can be difficult. So some people kind of don't make it through there. So there's so many levels at which that works. You're right. It's not just the end implicit bias training, maybe some marginal benefit. It really is kind of like broadening the scope of an aperture of who gets into medical school, nursing school, whatever rate, the kind of like allied health professions. I hate that phrase, but that's the best way to phrase it. All of those different providers that are in the hospital and in, outpatient settings that treat patients.
What challenges and opportunities do you see in maternal health over the next decade, and how's Organon positioning itself to address them?
Yeah. So I think that, like I said, we're in a moment now, which is great. There's recognition, in the clinical world, government, lay media, everybody recognizes that this is a problem. So now it's like, all right, first thing is acknowledge the problem, and then how do you move forward? I think our role is pretty straightforward. And again, it kind of goes back to the beginning, why I'm here. So, we're looking to like provide innovation in the space. And the one thing I will say, and this isn't racial, this is just general in maternal medicine. Like there's been
Mhm.
so little innovation in the space of maternity care, very little innovation in that space. Other things, preeclampsia, preterm birth. Like I think that, us looking into these different spaces that have been kind of under recognized or, under thought about in terms of development is really important. So that's probably our role as a pharmaceutical company. And then also on some level, obviously working in the policy space. And like I also mentioned, working with community-based organizations in terms of, them telling us like, hey, these are the things that are important. Like, how can you help us and how can we partner?
Oh, wow.
Yeah,
Well, Organon is right on the case as usual. You guys are doing amazing work.
we're
Dr. Davis.
trying.
Well, you're doing a terrific job. You seem to have a multidisciplinary approach that I don't see with very many um, companies. So I want to thank you, Dr. Damien Croft, for your work in this space and for your expertise and for your time today.
Thank you so much for having me. It was great.